Hello friends, today I'll be demonstrating a case of lap hiatal hernia repair. This is a port position. So once you are inside the abdomen, lift up the left lobe of the liver. Use a fan retractor or a Nathanson to retract the left lobe of the liver. If required, left lobe needs to be mobilized a little. So if you can see, the stomach was in the chest. Slowly it is pulled down. So no extra force needs to be put so that you don't perforate the stomach or injure the momentum. Slowly bring it down. That is the G junction fat pad which needs to be pulled down so that pars flaccida becomes prominent. So once the pars flaccida is seen, it is divided to get access into the space between the esophagus and the right crus. So once we open this, we'll be able to appreciate the left crus. So long-standing hiatus hernia will have a sac over the gastroesophageal junction that needs to be divided and brought down along with the stomach and the esophagus. So once you open this, you will enter the space between the esophagus and the right crus of diaphragm, which needs to be developed so that esophagus is completely mobilized from the right crus. A gentle dissection, combination of blunt and sharp, will allow us to demonstrate the esophagus. So all the suspensory ligament which are around the esophagus need to be dissected. So as high as possible, we need to cut all the suspensory ligament and also the vessels which are coming from the aorta to the esophagus, so that adequate length of esophagus is mobilized from the mediastinum back into the abdomen. So this video is run at 1.5 speed, so looks little faster, but a gentle dissection at this point of the time is very important so that the dissection planes are not obscured by the blood. So we need to be careful about vagi as well. Vagi need to be demonstrated and preserved. Sometimes the small vessels can bleed, which need to be taken control of. So once the left side is mobilized, the right side is mobilized, the attention is paid towards the left side where the suspensory ligament is dissected and the left crus needs to be demonstrated. Stay close to the esophagus and make sure that The pleura is not in your way of dissection. If it is found, it should be slowly dissected off the esophagus. So even if there is some rent occurring during the dissection, so most of the time nothing needs to be done. Just inform the anesthetist about it so that they'll check at the ventilatory parameters. So mobilize the esophagus as high as possible so that an adequate length of 3 to 4 centimeter lies inside the abdomen freely. So if this circumferential dissection is not done, there is always a pull towards the chest, which can fail our hiatal repair and fundoplication, and the entire flap can migrate up in the postoperative period. So that is the vagus, right vagus, which is seen, which is carefully identified and preserved. The phrenoesophageal membrane is opened on the left crest of the diaphragm to demonstrate it fully and to continue with the circumferential dissection of the esophagus. So esophagus will be tightly adherent to the crust, even the gastroesophageal junction, because of the hernia, so which needs to be dissected sharply and sometimes bluntly as required, so that the entire GE junction and the terminal distal esophagus come down easily. Small bit of attachments need to be taken care of for the complete distal mobilization of the esophagus. So with that, mobilization part is over. An umbilical tape is placed around the GE junction so that you get a good traction while doing the hiatal repair and fundoplication. Any non-absorbable suture or a delayed absorbable sutures can be used. We are using Ethibond here. A smaller needle is preferable for better manipulation. A good bite of crust is required on both the sides. So make sure that this repair is tension free. A tensed repair is bound to fail. It is going to give away. So if you see that if your disclosure is under tension, give relaxing incisions on both the sides of crura, followed by unabsorbable or a composite mesh placement. So we try to avoid mesh placement in as many cases as possible because of the known complications. But in case where there's a large hiatus where crural approximation is not possible or there is tension at the closure site with the relaxing incision, so in those cases we'll place a composite mesh in a C shape manner or a U shape manner. So make sure that your closure is not very tight. So a breathing space should be there for the esophagus, as now it is in a non-distended status. Very tight hiatal closure is not necessary. Closure can be started from above or below depending on surgeon's choice. 3 to 4 sutures might be required for the complete closure. So once the closure is done, now attention is paid towards mobilization of the stomach. So gastrocolic omentum is opened to enter the lesser sac. So 10 to 15 centimeter of stomach is mobilized entirely with taking down of all the attachments, including short gastric vessels, gastrosplenic ligament, and pancreaticogastric ligaments. Make sure that the dissection moves all the way up till the gastroesophageal junction, and the end point is demonstration of left crus. So this dissection and mobilization allows for a free 360-degree Nissen fundoplication around the lower esophagus without adding extra tension on the stomach or its orientation. So uppermost part of the fundus is mobilized behind the esophagus, and the shoe shine maneuver is done to see that it is freely lying down behind. So we use Prolene 2O suture for fundoplication. A good seromuscular bite is taken. We don't use esophageal bougie. We put a short floppy flap around the distal esophagus for a length of around 3 to 4 centimeter. Three nearby sutures are taken, one at the center followed by one up and one down, usually at a distance of 1 to 1.5 centimeter. Make sure that orientation of the stomach is maintained. So make sure that there is enough space between the plication flap and the esophagus. We don't take esophageal wall suture. So the umbilical tape is taken down, hemostasis is maintained. Remove the left lobe retractor and maintain the hemostasis. Thank you very much for watching this video.